It's important to have updated guidelines because on the average, about every 5 years, guidelines need to be updated just because of new information and how treatments are being done and new treatments that become available. What's unique about these set of guidelines is that it's the largest set of guidelines that the American Urologic Association has ever put out. There's over 50 guideline statements. Prior guidelines focused on the management of patients with ureteral stones and the management of patients with very large kidney stones called staghorn stones that occupy the whole collecting system where urine goes within the kidney. So these guidelines cover not only ureteral stones, staghorn stones, but all sorts of stones within the kidney, smaller stones, larger stones, stones in kidneys that have anatomic abnormalities. And we also focused on the management of kidney stones in both pregnant patients as well as children. It's very important that the physician and patient have a shared dialogue regarding the goals of treating their kidney stones and ureteral stones. And in this process, it's called a shared decision-making process that is focused in these guidelines, is that the physician presents the patient with information regarding treatment outcomes and expectations. And thus, the patient has a lot of decision-making in this process. The patient is certainly the one that's going to benefit from the treatment and needs to be involved. So it's a decision made with the patient and the physician, and the patient is presented with all of the information regarding the risks and benefits and expectations from the treatments that are available. The major changes in these guidelines is that we've really targeted where the utilization of what we call medical expulsive therapy. So this is the administration of a drug, typically an alpha blocker drug such as tamsulosin, to facilitate the passage of stones within the ureter. In our previous guidelines, we recommended that tamsulosin should be utilized in stones in all locations within the ureter. But data from our analysis of this most recent guidelines really indicate that it works best in the distal ureter. So it's really expressed in the document that it really is indicated in patients with distal ureteral stones. That's in the lower ureter. One of the changes in these guidelines is that for the management of patients who require stone removal of distal or middle ureteral stones, that ureteroscopy is endorsed as the preferred treatment for patients that have stones in these locations. Now, as a part of shared decision-making, the patient might decide to have a shockwave lithotripsy instead, but they just need to be informed that the results with regards to being stone-free with one treatment are superior for ureteroscopy. Stents are placed after ureteroscopic procedures in many patients. And one of the things that patients experience with stents are symptoms such as urinary irritability, a lot of urinary frequency, urgency, sometimes bleeding, sometimes some pain in the flank area with urinating, and sometimes some suprapubic pressure and pain. So in our guidelines, we state that you don't have to place a ureteral stent after a ureteroscopic procedure in certain settings. This is where a case is being done and the case goes smoothly. There's no evidence of a complication such as a perforation in the ureter, that the patient has a normal contralateral kidney that is functioning well, that there is no evidence of swelling in the ureter or any sort of anatomic obstruction that would impede the passage of stone fragments, and that where another ureteroscopic procedure is not being planned, for example, in a case where you can't get all of the stone out. So in those settings where the case goes smoothly and the kidney on the other side is functioning well and we don't anticipate any problems, if you don't leave a stent, then a stent can be omitted. One of the things that we recommend in the guidelines is that when stones are removed, that they should be sent for analysis. Knowing the composition of the stone can help you as a physician to counsel the patient on how to prevent stones. I was involved in a set of guidelines with regards to dietary modification and medical treatments for kidney stone prevention. As a rule, about 40 to 50% of patients that form one stone will develop another one within 10 years.